Hello, everyone, and welcome. Thank you for joining the Marfan Foundation and its divisions for our 2026 Global Virtual Conference session, Ask the Expert, Otolaryngology. I'm Stacy Watson. I'm the Director of Loeys Dietz and Marfan, and my colleague Meredith, the Foundation's Senior Director of Development, is behind the scenes helping to ensure everything runs smoothly during this session, and this session is being recorded. This Ask the Expert session will be a bit different than some of our other conference sessions. Rather than a full-length presentation followed by a brief Q&A, our speaker will begin with a short overview of the topic, and the majority of our time together can be dedicated to answering questions. To make the most of this format, please use the Zoom Q&A feature to submit questions throughout the session. We'll answer as many as possible. The chat is available for attendee discussion and comments, but questions posted there may be missed. So again, please use that Q&A tab. It's my pleasure to introduce our speaker. Stephen Goudy is the chairman of Otolaryngology ENT at Eastern Virginia Medical School at Old Dominion University. He is a pediatric ear, nose, and throat surgeon and is currently the president of the American Cleft Palate Association. His passions focus on caring for children who are born with developmental differences, and his clinical focus is on cleft and craniofacial differences from a patient care, surgical, and research perspective. His laboratory focuses on developing regenerative solutions for oral mucosal wound healing, the lining of your mouth, and bone regeneration. He started two companies, Dr. Knows Best and Iridivis, whose focus is on improving the health and well-being of children. Dr. Goudy, thank you for joining us. We are delighted to have you. Please begin when you are ready.
Great. So I am here on front stage with you. I am very excited that I found my way here, and I do realize in the comments that everybody that's here had to make choices between ENT and GI, and I saw that there's some comments about ENT and GI sparring, so I'm happy to entertain those. I put together some slides just to help you all think through uh, how I think about patients that have craniofacial differences. Um, let's see here. So I'm going to go with this and do that. So you guys will have to let me know if my slides are working. Is that, are we good? Yes. I'm just gonna keep moving, and if there are comments or issues with the slides, just let me know. So I'm going to talk about craniofacial impact of connective tissue differences that relates to Marfan, Stickler, Loeys-Dietz syndrome, and really thinking about the different areas of the head and neck, palate formation, cleft palate specifically with Stickler and Loeys-Dietz, but certainly facial differences also with Marfan syndrome. The airway, we can talk about that all day long. Upper airway, lower airway breathing issues, ear functioning, eustachian tube function. That's every one of the patients that the Marfan Foundation supports. Hearing also affects a lot of them, and speech can affect everybody as well, but certainly Stickler and Loeys-Dietz related to their palate. And, this is some of it's going to be some words, but some of it'll be pictures. And basically, when I'm meeting with families for the first time whose their child's facial shape didn't develop as we might expect, I explain to them that facial growth and development begins very early on. So fourth week, fifth week, sixth week of development, you may or may not realize that you're pregnant, and all of these tissues and cells are growing from the back of your head to the front of your head, and all of those areas are kind of meeting in the middle and joining and forming. And so here you can see that this is a schematic. This is a mouse, and there's cells growing from the front to the back, from the front around the eye, the upper jaw, the lower jaw, down to the heart, all of the cells that control not just your face, but also control your heart. So a lot of the children that we're discussing today not only have facial differences, but have heart differences. And that's because these cells that are going into these different areas are controlling or developing, helping with the development of the face and the heart at the same time. And so, what happens when you have a cleft or a separation in your face? These tissues are growing really fast to meet in the middle, but either they meet and they can't touch, or they can't grow fast enough to meet. And so, there's just a separation. And so, you can see here's a patient that has a cleft lip. This is just the different parts of your face. The yellow part actually grows straight down the middle, whereas the blue and orange parts grow from the sides, and they all kind of triangulate right there in the middle. And if you're looking up at the roof of your mouth, you can see that the yellow part, which is your front and lateral incisors, comes from the growth down the middle, whereas all of the other teeth and the hard and soft palate mostly come from the sides. And so, again, looking at the palate development, you have the tongue here in the early development stage. The tongue has to grow and push down. The palate shelves start from everybody starts out with a cleft lip. Everybody starts out with a cleft palate. And all of those tissues grow from the sides and meet in the middle and then join and infuse. And so if there's not enough growth, or the growth happens and they touch but they can't join, then there's a separation. And so that's what a cleft palate is. We typically are going to fix that around 1 year of age. This is just a schematic of how we do it. You don't really, there was a lot of other pictures in this presentation that I took out. I didn't want to gross anybody out, but basically we just take all the tissue from the sides and move it together to sew up the cleft palate. So this is a patient getting ready to have the surgery, and you can see here there's a gap between the oral cavity, meaning the mouth, and the nasal cavity, meaning the nose. And then we move all of those tissues to the middle. But you have these raw exposed areas there. Obviously, you've got stitches, it's the mouth, it's dirty. You can end up with wound healing complications. And so that's true of, patients with Marfan's disease. They can have wound healing complications, Loeys-Dietz, Stickler syndrome. Obviously, most of the patients that have Marfan's don't have a cleft palate, but you can have poor wound healing. So this is an oral nasal fistula. You can see some of those tissues didn't heal, where this is an even more obvious condition. So if your child had a cleft palate and they needed to have it fixed and it didn't heal correctly, related to the underlying differences in the genes, that are driving that development of the tissues, patients, particularly with connective tissue differences, have a hard time healing. And so understanding that, making sure that your surgeons understand, that's really important. Specifically as it relates to Stickler syndrome patients, a lot of them may have what's called Pierre-Robin sequence. Loeys-Dietz probably less common, Marfan probably less common, but Stickler syndrome patients have a relatively small jaw. They can often have a cleft palate, and then they'll have airway blockage or obstruction. So we have to position these babies on their sides, maybe put a plastic tube down their nose to help hold open their airway. Sometimes put a tracheostomy in, sometimes make a jaw lengthening procedure. And so you can see this little baby had a very short jaw. And again, it relates to the cells that are growing into the face. It doesn't pull the jaw forward fast enough. So the tongue doesn't pull out of the way. The tongue is blocking the airway and impeding or preventing the palate from forming. So in some patients, we actually may have to actually do a surgery where and these are all just schematics of the CAT scan, but we do a surgery to bring that jaw forward, to bring the tongue forward. And again, this is called mandibular distraction. So patients whose children have Stickler syndrome may have already gone through this, and because Stickler syndrome is typically autosomal dominant, you may have several family members who have had this done. But this is one way that we manage airway. We don't really do this if your child or your family member has Marfan's syndrome. Typically, this is not something we offer later in development per se. So this is usually just an early perinatal, or kind of around the time of birth. And so we bring that jaw forward. That's like us uploading the CAT scan to the cloud, us working with engineers who are kind of moving the jaw around virtually. We plan the surgery, then we do the surgery. And then, this is the bone that grows in as we lengthen the jaw. So again, from an ENT perspective, we're monitoring breathing, we're fixing cleft palates. We're going to talk about the ears. Another thing that we mentioned is the speech. Okay. And so speech can be impacted, particularly in Stickler syndrome or Loeys-Dietz. There's a typo there. So the palate is the roof of your mouth, and it pushes against the back wall of your throat when you're speaking. So puppy, Susie, baseball, fish. And so, if you have a facial shape difference, whether it's Marfan, Stickler, or Loeys Dietz, it may be harder for that palate to push against the back of your throat because the palate isn't closing completely and there's a lot of air coming out of the nose. So speech development is very important in children that have Marfan, Stickler syndrome, Loeys Dietz, etc. Because not just because of the palate function, but also hearing, and all the other things that go along with some of these different conditions. And so 20% of the patients after they've had their cleft palate repair will have a physical speech issue. So if there's air coming out of your child's nose, that's not more speech therapy because there's no amount of speech therapy is going to lengthen the palate. That typically means surgery. And so, we see it with a whole host of conditions. This is a schematic of the roof of your mouth, and you can see that these muscles here are supposed to go all the way across, and that's what lifts and elevates your palate. But if you're born with a cleft palate, those muscles aren't all the way together. We repair them so that your palate can elevate better. And 80% of the time they work great, but 20% of the time they don't work great. And then we would have to do another surgery to make the palate longer. The other interesting part is that this muscle here, called the tensor veli palatini, is also in your palate, and that's what pops your ears. And so, if you're going over a mountain or a plane, you're chewing gum, it's to make these muscles pull on each other, and that's what pops or opens up your eustachian tube. And so, for all of these patients, they're at risk for having ear problems, for eustachian tube problems, and it's probably in part because this muscle is working differently. How do we work up these speech problems? So we have our friendly speech pathologist evaluate your children and say, is it a structural problem? Is it an articulation problem? We may put a camera down their nose to see how well that palate is elevating and moving. We may also use an X-ray to see how well the palate is elevating and moving. So those are all of the kinds of things that if your child has a speech concern, that you need to get that checked out by a speech pathologist who's very familiar, with Marfan or Loeys Dietz or Stickler syndrome. And then lastly, I'll stop talking and we'll take questions. Is really tell us about the hearing loss. You're an ear doctor. Hearing loss can happen in many patients. And if you think, look at this picture here is the ear. Then you have the ear canal, the eardrum. So sound goes through the air in waves. And so it wiggles the eardrum, it wiggles the ossicles or the ear bones, and then it goes into the cochlea where it wiggles the fluid, and then it goes through the nerve into the brain. And so you can have issues, if you have a bunch of earwax, you're not going to hear as well because the vibrations won't going to get there. Or if you have a bunch of fluid behind the eardrum, that's also going to be a problem because the eustachian tube isn't working. Or if the hair cells inside the cochlea, which is the hearing organ, are not working as well, that can also be an issue. And so if you look at what does an audiogram look like, anything 20 decibels and above is normal. So if you can hear water dripping, it's normal. But if you can't hear the lawnmower or a jet airplane or whatever, you have very severe hearing loss. So this is just the ranges of hearing loss. And then getting into the different syndromes specifically, this is one study where they evaluated 70 patients with Marfan's syndrome and identified that up to about 50-ish% had hearing loss. The majority of it was on both sides, meaning bilateral. Some of it was on one side. The good news is that a minority, only 21% of patients had moderate or severe hearing loss. So a lot of it's in the mild to moderate range. And then CHL is conductive hearing loss. That means there's either fluid behind the eardrum or something else, or there's just pure nerve hearing loss and only 13%, or mixed hearing loss, which means it's a little bit of things moving and then a little bit of the nerve part. So again, and when your child is young, they can't tell you, I can't raise and lower their hand to tell you what they can hear. So that's why, again, you need an audiologist. You need a full team to support and take care of your children. And then, for Loeys Dietz, based on the different type of Loeys Dietz, you'll have different various impacts on the hearing, and it can range from mild to moderate. And on top of that, if you have a speech difference related to cleft palate, that can also impact things. Many of these patients will get ear tubes. On average, a patient that has a cleft palate will need about 3 sets of ear tubes in their lifetime. And then moving on, so again, there's the three main types of Stickler syndrome have a different, mild versus moderate versus severe hearing loss in the first three subtypes, whereas the fourth through sixth can have again different impacts on the hearing. Um, so from you don't need to memorize any of that. All you need to know is that your child should have newborn hearing screening and have passed it within a month of age. If they haven't passed it within a month of age, they need to confirm it, that the hearing may be not great by 2 months of age, and that there needs to be intervention by 3 months of age. So, and it's complicated, right? So if your baby has congenital heart disease, has other issues, airway issues, etc., hearing is probably lower on your list, but you need to have that in the back of your mind and being advocating for audiology evaluation, otolaryngology, ENT evaluation to make sure not only is the fluid clear, but that, there's not nerve hearing loss. Because the sooner you intervene, the sooner your child gets a benefit. If you don't engage those nerves, those hair cells in the inner ear, and you wait 6 months or a year and a half, those nerves really don't stimulate the same way. So you can't regain that function. But if you stimulate them right away, then you get a lot of those benefits. So, we talked about this newborn hearing screening. You got to make sure that if your child didn't pass that newborn hearing test, then you need to get a definitive diagnosis. It may require a sedated hearing test, which again, if you have airway problems or heart problems, that's going to be harder to kind of reconcile with, because you don't want to put a child to sleep for an hour and a half if you don't have to. But hearing is so important. There's lots of signs of not hearing, not responding to noise, delayed speech. And again, all of these patients need to be monitored. And if there is hearing loss, they will get hearing aids. They can get cochlear implants, other adaptive technologies. Obviously, seeing an ENT like myself, this is what an ear tube looks like. So if you look down your ear canal, here's the eardrum, this is the ear bone. We make a tiny hole in the eardrum, put a tube in there. It holds a hole open in the eardrum, lets all the fluid drain out. You can put antibiotic eardrops in the ear for treating ear infections, and you know that your child isn't going to be, having issues with blocked hearing. Um, and then as far as like, how do I take care of my child's ears? And this is my personal practice. I don't really worry about the ear tubes like getting underwater as long as it's treated water. So no lakes, no ponds, no oceans. I will follow you every 6 months until the ear tubes fall out. Then we'll monitor the hearing once the ear tubes fall out. And if there's fluid that recurs or there's recurrent ear infections, then we may end up putting ear tubes again. Typically, if your child has had a cleft palate, you don't want to remove the adenoids because, again, as we talked about, your palate's pushing against the back wall of your throat. This is where the adenoid pad is. So if you move that back a little bit, all of a sudden it can cause some speech issues. And I am going to stop there. And I will take any questions because I know that that was a lot of talking. And I'm also happy to talk about ENT versus GI or airway issues, speech issues.
I think that's a really great idea. The two questions that we have received before are both kind of ENTGI related. I will read you the first one that was submitted in advance. And the question is, as stated, I have VEDS. I'm wanting to know, is it common to have trouble swallowing food? I constantly feel that things get stuck. Have had endoscopies and nothing looks abnormal except for gastritis in the stomach. Any recommendations?
Yeah, I mean, I think swallowing is a challenge, and it's actually a fascinating topic. So I could talk about probably for 4 hours, but we don't have 4 hours. So one, you want to work with a good speech pathologist and a GI doctor, and ENTs get into it too. But if you think about swallowing, like you and I swallowing, we're under the we have control from the very tip of our lips until it gets in the back of our throat. So that involves coordination. Once it gets beyond kind of your little dangly thing or kind of into the back of your throat, that's all reflexive, right? So the reflexive part, is like things are kind of squeezing, right? The food has to go down. Your airway is in the front, your esophagus or your swallowing tube is in the back. So it really depends on where you feel like things are getting hung up, right? Like if you're like, okay, it's like I can't get it together in the front of my mouth, that's a very much a motor planning work with speech pathology to kind of see how are you eating? Are you chewing well enough? Whatever. But if it's like, hey, it's getting stuck down there, that's a reflex. And that we can evaluate with a swallow study. We can also evaluate it by putting a camera down your nose and having you eat stuff that's dyed green, or having your child eat stuff that's dyed green to see is it pooling, is it not going all the way down. There's a procedure called manometry where we put a little tube down your nose down all the way into your esophagus and in the stomach, and we can watch where the different parts of it squeeze. So, could it be reflux? Yes. Could it be inflammation of your esophagus? Yes. Could it be that the muscles are not contracting in a way that's like from top to bottom? So those are all the things that I would think about. If your child, if you're an adult and you have this problem, seeing a laryngologist or a voice doctor is actually what I would recommend if you feel like it's here or above. If you're like, hey, it's in the middle of my chest, then that was where a GI doctor would be most helpful. And probably if you have VEDS, I would want you to be at an academic medical center that sees and treats a lot of patients like this.
Thank you. All right, our next question. My interest is respiratory reflux, LPR. Is reflux more common in Marfan's? Is it specifically a problem with our lower esophageal sphincter? Note, the Kaufman diet and being aware of pepsin seems to be working fine for me. I'm 2.5 weeks in.
Yeah, I mean, I think ENT doctors blame everything on reflux. So I have to make that disclaimer. But certainly pepsin and other kinds of irritants, it's not just the acid, right? So it could be bile acids, it could be other things. So, is it more common in Marfan's patients? Or patients that have Marfan, my guess is that the esophagus is going to be longer, the connective tissue in the esophagus is going to be different. So I would imagine that it may be, but diet modification is a great way to do it. I think the Kaufman diet makes a lot of sense. There's other kinds of uh, non-medicinal, meaning like not taking Pepsid, and not, whatever the non-trade name is, or proton pump inhibitor. I just watched something on the news tonight that those medicines are one of the most overused medicines that you may see, and have lots of side effects related to mineral absorption and so on. So I think if you can control it with diet, and not necessarily dietary supplements, but there's other kinds of things like reflux raft, reflux gourmet, other things that help prevent acid buildup that don't involve taking medicines that turn off your acid producing system is probably what I would do. But then again, also having a GI doctor that follows you, because you can't, if you do have untreated gastric acid reflux a lot, then you can develop something called Barrett's esophagus, which is not good, and it could potentially be cancerous or precancerous.
Thank you. Okay, our next question is deviated septum in someone with VEDS. More common? Is surgery contraindicated?
Um, I don't, I mean, I think it would probably be unrelated to having VEDS. I think, deviated septum, I think half the world or more probably has a deviated septum to some degree, but most people it doesn't bother them. I mean, the reason why I tell my patients to consider it, I mean, certainly if you have condition like sleep apnea or something where you have to wear CPAP, it can make that more tolerable. Otherwise, like if it doesn't bother you a whole lot, I wouldn't mess with it. It's not, I mean, if your cardiologist says you're okay to have surgery, I wouldn't worry about having surgery, but it's like, do I want to go through it? It's not that much fun because basically your septum is like a wall between the right and left side of your nose, and it gets pushed over like somebody hit the wall and it smushed it over. So we have to go in surgically while you're asleep, take all the wallpaper off the wall, straighten out the insides of the wall, and then put the wallpaper back together. And typically we hold it back together with big plastic sheets. So if you want to go on TikTok or whatever and watch people having those pulled out of their nose, you can see what it's like, but they don't really love it for the week that's in there. There are office procedures where people will break your septum back over in the office. That doesn't sound like a lot of fun to me either, but it may be less invasive. But I don't think it's related to VEDS. I think it's just related to, it just happens.
Thank you. Another question, is mammometry,
Yep. I know.
mammometry, did I say that
Yeah.
right? Okay.
Yeah.
Or camera scope contraindicated with vets?
No, I don't. I mean, I can't I can't think of why that would be. I mean, you know, no, I don't think so. I mean, manometry is putting a tube down your nose into your stomach.
Mhm.
Um, yeah, I couldn't think of a reason why that wouldn't be okay, but certainly, maybe there's something I'm not thinking about.
I'm wondering if this person is asking because it can be really hard to find people who are comfortable doing like colonoscopies and endoscopies in folks with veds. And so that might be why they're asking specific questions about scoping in other ways. So
Yeah,
if
I mean, that's
yeah.
why I think being at an academic medical center or a center, a hospital that actually knows what VEDS is, right?
Mhm.
I mean, if they're like, I don't know what this is, I mean, you just don't want people that don't feel comfortable trying to take care of you, right? But I don't see any, I take care of lots of patients with VEDS and Marfan and Stickler and Loeys Dietz because I'm in a big place where people are like, okay, well, we understand, it's not the first time they've heard of it. They're like, okay, well, we'll just talk to the cardiologist and if they say it's fine, we know how to manage this or what have you, or the geneticist, whatever the case may be.
Great. I really like this next question because I have this too. This person is asking about stating that they have a constant crunching, like a pop rock noise in their neck and mild neck pain, no matter what they're doing. Is this something to be concerned about for people with connective tissue conditions? They are speaking from a stickler's perspective. I'm speaking from a Louise Dietz perspective.
Yeah. Um, Number one, and this is my personal opinion, right? This is not medical advice. I wouldn't go to a chiropractor, right, to get this sorted out. It just wouldn't. I mean, particularly if, working on the neck, there have been case reports of the vertebral artery being injured from neck adjustments. So my advice as a human being was don't get your neck adjusted, particularly if you have a connective tissue difference. I will say I personally have this from time to time. I don't stop and really think about it. My guess would be that it would be muscular tension versus vertebral, like bony issues. Could it be? I think so, but I don't. There are plenty of conditions that we treat that are associated with vertebral differences. So golden heart syndrome or hemifacial microsomia, craniofacial microsomia, that they have cranial like bony differences in their neck. But if you're having tightness or crunching or whatever, I would see a physical therapist. do some other things. But yeah, that's what I would do. But is it directly related to a connective tissue difference? I guess so, because the muscles are all made of connective tissue. But would I worry like, hey, I have a disc herniation or whatever? I would not worry about that necessarily.
Thank you. Okay, that is all the questions that came through the Q&A. So I'm wondering, I would just want to give folks a moment to finish typing if they are. I'd love to hear a little bit more about your perspective around like sleep and getting good quality sleep and what recommendations that you might have from an ENT perspective. I think that's something that not a lot of us always think about and how it affects our quality of life and everything else that we do. And you did start kind of mentioning that a little bit when we were talking about the deviated septum. So
Yeah.
yeah.
Well, I mean, I think sleep is very important, and we all understand and acknowledge when we don't have good sleep. I would, and certainly I guess I kind of left it off of this talk, but certainly sleep is probably one of the bigger things that I deal with as a pediatric ENT in children. The data are that, I don't know, 20%, maybe not 20, but 10% of children snore or have other breathing issues, and that sleep apnea is incredibly common. Obesity is increasing in our society. So, getting sleep for your children is incredibly important and related to their performance at school and growth and learning and so on. And, patients that have snoring, gasping, choking, pausing, the screening for sleep apnea in this patient population is incredibly impactful because not only does it, not only are the facial structures different, which impedes airflow, which causes breathing issues. Sleep apnea is not good for the brain, and it's also equally bad for the heart. So I see patients, that end up in right heart failure because they're having so much airway obstruction. So I think making sure that you have good sleep is good, and I think making sure that your children that have these differences aren't snoring, aren't gasping, aren't choking, aren't sweating at night, aren't wetting the bed. ADHD is also a very strong correlation with sleep disorder breathing. So, sleep is huge. I think we all recognize that.
Thank you. I think we got through all of the questions that were coming in from our audience. Oh, never mind. I spoke too soon. Here we go. My son of 22 with LDS type 2 suffers with chronic Pseudomonas. Did I say that right?
Yep.
Pseudomonas
Perfect.
infection bilaterally and is rarely free of infection. He has bilateral total perforation and finding little window infection free. The surgeon attempted a successful tympanoplasty, and within a month, he started to have several holes in the graft that led to total perforation. His infections are continuous and exhausted all treatments as he is coming resistant to them. The consultant is just monitoring and doing suction when they can. Do you have any advice for this individual?
Absolutely. That's a tough issue because children and adults that have connective tissue differences are different at healing, as we discussed. We put ear tubes in to treat the fluid so they can hear, so they can speak. But then when the ear tubes fall out, the holes don't close, and then they can get bigger. So Pseudomonas is a bacteria. It's very commonly associated with having ear tubes, very commonly associated with having holes in eardrums, and it can be hard to get rid of. Typically, when I have this scenario in my office, I'll get a culture of it, meaning clean out the ears with a little vacuum cleaner. Kids don't like to see me coming with a vacuum cleaner. Hopefully, now that your child is 22, they tolerate it. So cleaning it out is great, and then putting topical antibiotic ear drops into the ears is very helpful. Making sure that water isn't getting in there. So baths or showers, putting earplugs in or, putting in cotton balls that have ointment on it just because you want your ear canal to be dry, and really you can use a hair dryer on a low setting, several feet away from your ear to dry it out. They actually sell ear dryers on Amazon. And say really keeping the ear dry, getting a quality, specimen to see if it's a resistant bacteria, and then treating it specifically to that bacteria is important. And then if that's not making any headway, then I would see an infectious disease doctor and just see if there's other types of antibacterial medicines that can be given. Sometimes we'll actually have a compounding pharmacy make kind of I wouldn't it's not witchcraft, but you can, there's only so many kinds of eardrops that they make, right? But there's lots of other antibiotics. You can actually get them to grind up certain pills and then we can spray it into the ear to kill the bacteria. So uh, some ENTs will do that. But it's a tough problem. And I'd also make sure his hearing is okay and consider hearing aids or other kinds of hearing adjunctive devices to make sure that it's not, impacting his hearing significantly as well.
So just because I happen to know the individual who submitted that question, um, uh, they are not in the States, they're in the UK. Do you have any maybe insight into that system and some advice for them in that regard?
Yeah, I mean, I know the ENT folks. Well, number one, I'll be coming to London so we can talk in person. But no, I mean, there's plenty of good, ENT doctors in the UK. Obviously, your access to healthcare takes a different route there. But I would hope that this patient's plugged in with an ENT, again, in a center that's familiar with things. I would say the other thing that's kind of hard is the transition to care, and I'm sure you guys talk about it a lot, like on the American Cleft Palate Association side. We talk about it a lot. Like once you leave that like care nest of pediatric providers and like get pushed out into the cold realities of adult medicine, it can be very different, and you don't have a care team that's going to support you in the same way. So making sure before you make that transition that you have your ENT doctor, your cardiologist, your geneticist, your whatever person hand you off to somebody that will actually know kind of what you're doing. So, and I know this is a long answer, but I would probably want to see something called an otologist. So that's somebody that did 2 years of extra training just to see, or just to focus on the ear. So, if you're having chronic issues like this, then, I would get in line to meet with one of those folks.
They asked a follow-up question just about acetic acid. Is that
Yeah.
potentially a good option?
Not with a huge hole in your eardrum. I mean, you have to be so acidic. So the ear canal is typically acidic. Like there are other parts of your body that have a specific pH, and when that pH gets off, things go haywire, right? So the ear canal likes to be acidic. And so we'll use that a lot, particularly it's more for fungal infections, like fungus gets in there and it gets gross and will acidify it. But if you have a big hole in your eardrum, you have to be very cautious about what medicines you put in your ear because it can also make you go deaf because it will get right into around your inner ear, if you will. So I would be cautious about using a lot of acetic acid in this scenario.
Well, thank you. Thank you
Yeah.
so much for answering so many questions for us. Um, I learned a lot myself, so thank you for that. And we're very excited that you're going to be joining us in London in October. I know the whole crew over there is going to be really happy to hear from you. Um, and I just want to thank everybody who submitted their questions and to Dr. Goudy for sharing their expertise and insights. If you weren't able to get your question today, or you think of something later, you can reach out to the team at the Marfan Foundation's Help and Resource Center. We could assist you with questions and answers really specific to your own situation. And you can reach us at marfan.org/ask. and a member of our team will get in touch. Thank you again, everybody, for joining us. Take care and enjoy the rest of conference.
All right. Thank you.